In the OPD, a gentleman came who was having the doubt that he was not a diabetic, but in a OPD that he was shown outside, he was given the drug Dapagliflozn. So, with the doubt, he came in the OPD. The topic of discussion is related to that Dapagliflozn, the important clinical information. Dapagliflozn belongs to the group of drug which blocks sodium glucose co-transporter, which is present in the kidney, to be specific nephron, more specific proximal convoluted tubule. So what is the role of this channel? This channel reabsorbs sodium and glucose once it is filtered from the glomeruli. Basically, it prevents the glucose from getting lost in the urine at a normal level. Whereas in diabetic patient, the glucose is already high. So there are drugs which is available. Through various mechanism, it try to brings the glucose down. And this drug is also having one of the mechanism which reduces the glucose in the body. How it do? It is blocking the reabsorption of the glucose so that it will be released into the urine. So the basic mechanism is sodium glucose co-transporter blocker, SGLT2 inhibitor. Is this the only drug? No. In the gliflozin group, there are other drugs also there. Dapagliflozn, canagliflozin, empagliflozin, and more other gliflozins are coming in. Since it is for diabetic, why it is being given in non-diabetic patients? See, apart from its primary mechanism, through various other effect of this particular drug, the sodium glucose channel is blocked. The sodium is also released into the tubule. The excessive sodium in the distal tubule activates one mechanism which prevents the hyperfiltration. What is that mechanism? It is tubuloglomerular feedback. Thereby, hyperfiltration reduces, thereby fibrosis or progression of the chronic kidney disease reduces. Add-on mechanism. Third one, it is having some kind of diuretic effect. It is having impact over a period of time, causes minimal weight loss, reduces the oxidation, and in the heart it also blocks one more channel, sodium H plus channel. Probably these are more technical terminology, and there is already a video on the channel regarding the technical description of this particular group of drugs. So leaving aside this drugs having some pleiotropic effects apart from blocking the sodium glucose co-transporter in the kidney. Because of this varied or pleiotropic effect, either directly or indirectly, these drugs having other benefits. The important clinical condition where it is used. First, leaving out the diabetes. In type 2 diabetes it is being used. Second one, in chronic kidney disease, to reduce the progression, this drug is effective. And also in proteinuria, it reduces the proteinuria through various mechanism. That technical part not I went into detail. In summary, it blocks hyperfiltration, thereby reduces the harmful effect on the kidney. It have minimal weight reduction property. Cardiovascular benefit. It reduces the cardiovascular mortality. It is being promoted in cardiac condition also because of the cardiovascular benefits. It reduces the uric acid level. It reduces the overall oxidation. And some studies have shown it reduces the or stabilizes the lipid profile also. So clinically, apart from diabetes, even if the patient is not diabetic, in chronic kidney disease and in conditions of proteinuria, it is being given in nephro-related situation. Whereas cardiac also, for the cardiovascular benefits, the patient is a diabetic, yes, it can be added as a add-on therapy. So diabetes, kidney problems, heart, uric acid level, weight reduction, mild diuretic effect. These are all the important situation. So coming to the initial part of discussion, the patient was started on dapagliflozin for the renal benefit despite he not being a diabetic. So this is one important point. So what is the dose? 5 milligram and 10 milligram. The maximum dose is 10 milligram per day. If the patient warrants, considering other clinical situation of the particular patient, it can be started at 10 milligram or it can be started at 5 milligram and the dose can be titrated. So we have seen mechanism, we have seen the clinical benefits, dose. Coming to the important one, the side effect or the adverse event. Whenever a drug is having some benefit, it is always associated with some side effect. What are those? Most commonly UTI and genital tract infection. Genital tract infection can be mycotic, non-mycotic, more of vaginitis in female, in male also more of UTI. So whenever a patient is having recurrent UTI, don't start this drug. This drug should not be started. Second, since it is causing some kind of diuresis, in the sense it causes some kind of water loss. So the patient have to, or the person who is taking this drug have to be adequately hydrated. Third, some serious side effect, euglycemic ketoacidosis. Euglycemic ketoacidosis is nothing but even at a lower sugar, let us take sugar as 250 milligram per deciliter, the patient can develop severe acidosis. This is called as euglycemic ketoacidosis, rare but serious side effect. Apart from this, 30% rise in creatinine can be expected. So that is why before starting the drug, do the kidney function test. After starting the drug, within 10 days or maximum 2 weeks, repeat the drug. If there is 30% rise in the creatinine, better to stop the drug. And apart from this, there are group and drug specific side effects are there, like reduced blood supply to the distal digits, that is high chances of gangrene. There are some other drug which increases the risk of amputation. So in toto, UTI, euglycemic ketoacidosis, and there is a chance of AKI. These three have to be looked for. Dehydration is common whenever there is a patient is losing volume from the body, better to stop this drug. So this is the clinical info which are related, and to close this video, dapagliflozin can be given even if a patient is not diabetic, considering the CKD progression and the proteinuria, and also for cardiovascular benefit. Dose 5 milligram to start with, or to 10 milligram also if the condition warrants. Look for UTI. If recurrent UTI, stop the drugs. And 30% fluctuation of creatinine is possible. Stabilization, you can continue. And one more clinical point that we get the references before concluding, just one more point. If a patient is started on dapagliflozin for CKD and the CKD progressed, EGFR went below, that is the cutoff. I forgot to tell, the glomerular filtration rate above 30 ml per minute, it can be given safely. If it is going below 30, not to initiate. Suppose the patient is already initiated on dapagliflozin, you can continue the drug, not because of the kidney benefit, but because of the cardiovascular benefit. So this is one point that I missed in the discussion and added in the summary. Bye bye, we will see in the next video.